So this session on cancer epidemiology is facilitated by two of our colleagues, Miriam Mutebi. Miriam is a surgical oncologist at Aga Khan University Hospital in Nairobi, Kenya. And we also have Dr. Christine Nguria, who's from Yale University. So ladies, we're looking forward to this session, and over to you to take it away. Thank you.
All right. Thank you so much. And welcome everyone to this cancer epidemiology session. My name is Miriam Mutebi, and I'm a breast surgical oncologist and Vice President of East Africa of Aortic. I'm going to quickly let my co-host introduce herself. Christine?
Yes, good afternoon, good evening, and good morning, everyone. My name is Dr. Christine Nguria, and I'm on faculty in the Department of Emergency Medicine at the Yale School of Medicine. It's a delight to be here and look forward to a riveting discussion with you all.
Absolutely. Welcome, Christine. We've had a couple of challenges getting our speakers on board. I think a few people have had issues logging on, but we do have the irrepressible Chemtai Mungo to share her study with us. And so let's get quickly into it, Chemtai. Welcome. Chemtai? Sure, we'll probably give Chemtai a couple of minutes to log back in. But I think, Christine, one of the key areas that we sort of think about, especially with cancer epidemiology, is really looking at the distribution, determinants, and frequency of disease in our populations. Perhaps some reflections on why we feel this is critical for cancer care. I don't know if you have any preliminary thoughts around that.
Oh, and we got our lovely professor back. We'll continue that thereafter. Dr. Mungo,
right.
Share your screen, and we'll jump right in.
All right, thank you, everybody. Okay, so hopefully the internet cooperates. So my name is Dr. Chemtai Mungo. I am an obstetrician gynecologist and assistant professor at the University of North Carolina. I'm very happy to be here and to talk to you about secondary prevention of cervical cancer among women living with HIV in Western Kenya. I have no disclosures. So we are all quite aware here that cervical cancer is a disease of great disparity. Of approximately 600,000 cases that are diagnosed each year, 85% of incident cases occur in low-income countries. And unfortunately, 9 out of 10 women who die from cervical cancer live in low and middle-income countries, as many of the delegates of this conference have experienced themselves. So within HIV, there is sort of dual epidemic amongst women who live with HIV and cervical cancer. Cervical cancer is a disease that has been well elucidated, and that is why it's very preventable. Throughout the cascade of cervical cancer incidents, women living with HIV have higher risk. Starting from HPV acquisition, HIV-positive women are more likely to acquire HPV. They're less likely to clear HPV due to immune suppression. Once they develop precancerous lesions, HIV-positive women have a faster progression from cervical precancer into cervical cancer. And when cervical precancer is treated in HIV-positive women, they have higher recurrence rates, so they have higher failure rates. And this ultimately results in much higher incidence of cervical cancer amongst women living with HIV, with about 5 to 8 times increased risk. We also see higher, younger age of diagnosis because of this aggressive form. And really this results in a need for urgent tools to prevent this preventable disease amongst these women. So a lot of work has been done in the era of HIV prevention and now thinking about HIV cure. And compared to the 1990s, now we most women have access to antiretroviral therapy. But the gains in HIV care have not translated into cervical cancer prevention. So one question is being on antiretroviral therapy protective against cervical cancer for women living with HIV? This is a study that looked at this question amongst women in South Africa, Latin America, North America, and Europe. And looking at South Africa, at 5 years of being on ART, the incidence of cervical cancer did not change. In fact, it increased. While these other countries, the incidence is much lower. And this really reflects a lack of secondary prevention. So whether a woman is on ART or not, unless you screen and treat precancer, she will get cervical cancer and unfortunately has a very high risk of dying from it. So how about immune suppression and CD4 counts? Again, many of the ART clinics are doing a fabulous job of working on viral suppression as a tool for preventing HIV transmission. But we're not seeing the same effect of CD4 counts being protective against cervical cancer incidence compared to other cancers. So this is data comparing Kaposi sarcoma, non-Hodgkin's lymphoma, CNS lymphoma. And in some of these other cancers, we see that as patients have higher CD4 rates, their rates of these cancers decreases, including Kaposi sarcoma, which we see a lot in sub-Saharan Africa. However, within cervical cancer, you don't see this linear relationship. So just because a woman has good viral suppression, high CD4 count, she still has a pretty high chance of getting invasive cervical cancer. What's the survival of following a cervical cancer diagnosis for women, HIV-positive women in LMIC settings? So these are really grim statistics, but these are two studies from Uganda and Botswana that illustrate really this failure of the prevention cascade and really the secondary prevention cascade. In Uganda, looking at women, comparing HIV-positive and HIV-negative women at 24 months following a diagnosis, only about 30% of HIV-positive women were still alive following a diagnosis of cervical cancer. And the difference was a little bit better, where about 50% of HIV-negative women were alive. And this data in Botswana is pretty similar, where at 36 months, you only have about 30% of HIV-positive women who are still alive. So really, a diagnosis of incident cervical cancer is really a death sentence, unfortunately. And this speaks to many of the issues that have been discussed in this forum about lack of first late diagnosis and lack of tertiary care. Again, this is a very preventable cancer. So really, this is a moral imperative, cervical cancer prevention amongst HIV-positive women. I quote the former president of the United States, George W. Bush, who said, "It makes no sense to save a woman's life from HIV/AIDS, only to let her die from a preventable or treatable cervical cancer." So while PEPFAR has revolutionized HIV care, and many women and men are living with HIV as a chronic disease, really, we can't not address the cervical cancer burden because we are losing the gains of the hard fight on HIV/AIDS. And thanks to a lot of work, a lot of research, we now have a blueprint for elimination with a recent call from the WHO to eliminate cervical cancer, acknowledging that we do have the tools with primary prevention with HPV vaccination, with secondary prevention with highly accurate screening tests, in particular HPV screening. The recent validation of self-sampling for HPV screening that vastly increases the ability to reach multiple women. And then with a push to treat precancer, because we know that screening itself is not enough. You need to treat the precancer to prevent incident cancer. So we're all working with this 90-70-90 targets of elimination with the hope that by 2030, we can reach this threshold of less than 4 cases per 100,000. And we all know that we have a lot of ways to go. So focusing on secondary prevention, which is preventing incident cancer amongst women who have not been vaccinated. We know that HPV screening with HPV tests is very highly accurate, it's cost-effective. It can catch women who have precancer, and especially with self-sampling, women can be screened in the community. They can be screened during health fairs. You don't need a pelvic exam. Really revolutionizes the ability to reach the elimination target. The second part is the treatment. So how exactly are we going to treat precancerous lesions, and what's the evidence for it, especially amongst women living with HIV? We know that recently handheld thermal ablation devices were approved by the WHO. So in 2019, the WHO approved the thermal ablator, which comes in multiple formats, which is a handheld ablative device which uses heat to destroy abnormal cells in the cervix and treat precancer. This replaces the prior use of cryotherapy, which has been ongoing on the continent for several years, but unfortunately had multiple problems, including the fact that these gas tanks were very heavy. So if you're trying to do a community outreach in a very rural clinic or rural community where there are no roads, you need a big truck to carry a 90-kilo gas tank. Also, if you're in a rural community, again, once the gas tank is over, you can't replace it. So the recent WHO endorsement of thermal ablation potentially is a game changer in really closing that screening and treatment gap. But as scientists, we always need to ask, what is the evidence for thermal ablation, especially amongst HIV-positive women? Again, knowing that this is a very high priority population, given their higher risk and the known risk of treatment failure. When thermal ablation was the primary data that formed the bedrock of the WHO recommendation was data from the UK, where there was not a lot of women with HIV who were being treated with thermal ablation. So while this is a method that has been endorsed, there are several questions about its use in LMICs, in which my group and others are trying to answer. So over the last 3 years, as a fellow, I conducted a study looking at to really fill this evidence gap of what is the safety, efficacy of thermal ablation for treating high-grade precancer amongst women with HIV. Again, noting that we do need local evidence, and much of the data was from the UK, where the efficacy rates were very good, but we know that those are very different settings. In Scotland, for example, which is not in the UK but it's in Europe, most of the people who provide treatment for precancer are physicians, often obstetrician gynecologists. But we know in sub-Saharan Africa, most of the people offering screen and treat are nurses, sometimes clinical officers. Rarely is it a medical officer. So this study looked to answer this question. Is thermal ablation, as performed by a non-physician provider, safe, acceptable, and effective for treating high-grade precancer in HIV-positive women in a low-resource setting? The study enrolled approximately 400 women who were HPV positive, also HIV positive, ages between 25 and 65 years. It ran between 2019 and 2021 and was registered on clinicaltrials.gov. The primary outcome was looking at safety, and that was defined as pain and adverse events, as well as acceptability. And the secondary outcome was looking at efficacy for biopsy-confirmed CIN23. Really, does thermal ablation adequately treat the lesion that is most likely to become cancer and result in that really high mortality rate for a woman? This work took place in Western Kenya, in Kisumu, which is around here on the map. And work was part of a collaboration. It took place in PEPFAR-funded clinics that provide HIV care, a collaboration between the University of California, San Francisco, and the Kenya Medical Research Institute. And the FACES, the PEPFAR collaboration, is a host several big studies that many have heard about, including the SEARCH studies, PrEP studies, etc. And this area in Kenya is particularly devastated by the HIV epidemic, with HIV prevalence rates about 15%, which is about 3 times the national average. So overall HIV prevalence in Kenya is about 6%, maybe even a little bit lower. But for various reasons, Western Kenya and Kisumu County in particular has about 15% HIV prevalence. Hence, these women have a severe burden of incident cancer without access to prevention. So reporting results from this study. So our primary outcomes, again, was safety and acceptability. These data were peer-reviewed and are available in an open access journal called Global Oncology. We evaluated safety and acceptability using a standardized scale from the Division of AIDS, the NIH. We report data from about 300 women who had this very standardized evaluation of safety. So a clinical officer provided thermal ablation to all women. Women were asked questions immediately after treatment about their experience with treatment, about pain with treatment, and then they were evaluated 4 weeks later for adverse events, including bleeding, discharge, pelvic pain. Did you need to be admitted to the hospital? Any other concerns related to safety and acceptability? And overall, we report a very excellent safety profile. For pain during treatment, 5% of women had no pain whatsoever. Again, we know that ablation is often done without anesthesia. That's the same with cryotherapy. And it's generally accepted that it's a very safe procedure. And we confirmed this data with 79% of women reporting mild pain. 14 reported moderate pain, and only 2 women reported severe pain. In logistic or multivariate regression, women who were slightly older or women over 40 years were more likely to report moderate or severe pain. But again, no women needed to have the procedure stopped because of pain. Women reported vaginal bleeding after treatment. This was evaluated at 4 weeks post-treatment, approximately 4 weeks. Approximately 33% reported some type of bleeding. The majority was mild, 96%, 4% was moderate. The median length was about 3 days. Again, nothing overt. Vaginal discharge is a very common side effect of ablation, as well as excisional therapy. And this, not surprisingly, almost all women reported vaginal discharge. Again, this was all mild or moderate, lasting a median of 14 days. There was no infection, no one needed antibiotics. About 18% of women reported some aspect of pelvic pain in the post-treatment period. Again, most of these were mild, 80% were mild, 20% were moderate. Nobody had severe pain. And all women who had moderate pain used over-the-counter medications and were fine. Again, there were no other complications with treatment. Women reported very high acceptability, with 99% saying they would recommend ablation to a friend who needed it. And we found that most women were able to adhere to the recommended abstinence period, which was approximately 6 weeks. And the mean abstinence period was 5.8 weeks. So this safety data really supports the current effort to scale up ablation as a safe procedure that can be performed in the community by a trained nurse, by a trained clinical officer. The next biggest question for our field, I think, is what is the evidence for efficacy? In particular, how well does ablation treat CIN2-3, which is the high-grade pre-cancer that is most likely to progress to cancer if it's not treated? So while ablation is approved for treatment within CN-treat programs, the WHO contends that there are few studies evaluating cure or other outcomes with thermal ablation in HIV-positive women. And this is true because remember that thermal ablation was widely used in the UK and Scotland, but primarily amongst HIV-negative women. So this is a key critical kind of knowledge gap for the field. There's a systematic review that was published by Randall et al. That had 23 studies that reported efficacy of thermal ablation. And this study reported very high cure rates, about 94% cure rate for biopsy-confirmed CIN2. Again, this is the lesion or the abnormality that we most care about because this is what will result in cervical cancer. However, again, speaking to the lack of data, this systematic review mostly had HIV negative women, and really there was no study from Africa with biopsy confirmed CIN2 plus. And so this led to a conditional recommendation saying from the WHO, saying that there's a need for studies on thermal ablation cure rates of histologically confirmed CIN being very urgent, especially in women living with HIV. So why is this important? We all know that as part of the 90-70-90 elimination campaign, we need to screen and most importantly, we need to adequately treat. And I think the question of adequate treatment, especially in HIV positive women, is still kind of an open question. We know from other studies that there's two ways to treat cervical precancer. You can ablate or you can excise. Excision involves removing a chunk of the abnormal tissue. It's usually through something called a LEAP, which is a more involved procedure. It requires electricity. It requires more training. And that's why ablation is very attractive because it can be, scaled, in places with no electricity. It can be done by nurses. But we have data that ablation may be less effective in HIV positive women. So this randomized trial that compared cryotherapy, which is an older ablation method, the one with the gas tanks, compared to LEAP, which is an excisional method. These were HIV positive women in Nairobi who had either procedure and were followed up for 2 years. And this very rigorous study found that women who were in the ablation arm had a 30% recurrence of CIN2-3 compared to only 20% in the LEAP arm. So we already know that there's some data that even though ablation is very scalable, it's easy to use. Nurses can do it, especially women with HIV, because of the issues of immune suppression, amongst many issues. It might not be as effective. And we also know from good data that lack of adequate treatment of CIN2-3 really predisposes a woman to incident cervical cancer. So this was a study from Lancet Oncology that quantified this risk and showed that the incidence of cervical cancer was 50% amongst women who had persistent CIN3 within 2 years. So women who had CIN3 in particular was treated and it was not adequately treated, had chance of progressing to cervical cancer was 50% within 2 years compared to those who were adequately treated. So this is really important because we see, especially in the context of not good follow-up, if we treat a woman and if she's not adequately treated, she comes back in 5 years, she might have incident cancer. That's why it's critical for us to really nail down how effective ablation is in HIV positive women. And, we do need rigorous data on efficacy. So we know that while visual inspection with acetic acid is a very easy and cheap way to look at the cervix and potentially look at abnormal lesions, there's too much subjectivity. The test characteristics of being able to say, I'm seeing this and this is, precancer, this is a cure or not, is not very good. So unfortunately, many clinics currently that are using ablation for treatment are using VIA to evaluate efficacy. But we need to have good data, being biopsy-confirmed data, to tell us whether or not a woman who had cervical high-grade precancer, particularly CIN2-3, on biopsy had cure, which was also kind of diagnosed or verified via biopsy. So as part of this study, we recruited total of 379 women who are HPV positive. They all underwent colposcopy. They all had biopsies, and they're all treated with ablation as part of the HPV and treat protocol. We identified 67 women, about 17%, who had CIN23 on biopsy. Again, these women were treated with ablation by part WHO criteria. These women had 12-month follow-up where they again had colposcopy. They had either a directed biopsy of a persistent lesion or they had a random biopsy. And again, we biopsied women, even those who did not have a lesion, because we wanted to say for sure that they were treated with CIN23 that they were diagnosed with. And so far, approximately 90% of these women have been seen for follow-up. And I present here preliminary results that are still undergoing pathology double verification. But we do report approximately 23% of women who had CIN2 had persistence at 12 months. And up to 37% of women who had CIN3 at baseline had persistence, meaning that on biopsy at 12 months, they continue to have CIN3. The confidence intervals are wide because the sample sizes were small, given that we started with a group of 67 women. But, this shows us that potentially, we are still having high recurrence even with this very good treatment. So in conclusion, we find from this preliminary data that thermal ablation is safe and it's highly acceptable as provided by a non-physician provider in low-resource settings. It's safe and acceptable amongst HIV-positive women. However, our preliminary data, which we actually are fully presenting next week at the HPV meeting, reports that we may have lower than previously reported or expected efficacy for biopsy-confirmed CIN23 amongst HIV-positive women. This calls for more rigorous data. We really need more studies, ideally randomized trials. And I know there's one going on in Zambia that have biopsy results at baseline and at follow-up that can really tell us whether thermal ablation can adequately treat CIN23 and hence, kind of be part of the 90-70-90 elimination. There are several questions that are unanswered. Those of us in the field of cervical cancer prevention and treatment in particular, in regards to ablation. So whether the length of treatment matters, whether you can in 20 seconds versus 40 seconds per treatment changes a cure rate. This is a question that's not been answered in the WHO guidelines, and more data is needed. There's also questions about the type of technique that is used and whether using two different types of probes might result in a higher cure rate. And I'm curious to hear from those who are doing ablation. Another question that's unanswered in this field is whether or not these battery-powered devices that are excellent, very scalable, might have different efficacy compared to the desktop-based devices, which are the ones that were used in the original trials, which most of the data is based. So these are all questions that we need to sort of address over the next few years. I want to thank my co-authors and collaborators from Western Kenya who are listed here for this, their support in this work, the participants, my mentor, Dr. Craig Cohen at the University of California, San Francisco. And this work was funded by the American Society of Clinical Oncology Young Investigator Award. That's it. Thank you.
All right. That was truly excellent, Dr. Mungo. Definitely very enlightened. I have several questions, and Dr. Mutebi and I will be tag teaming that. We just wanted to remind the audience, please do post your questions in the app so we can get questions and comments so that we can share those with Dr. Mungo. I think, first of all, Dr. Mungo, we just wanted to hear a little bit more about you, your background. So can you just enlighten the audience a bit on what led to you being here, particularly focusing on this area of research, just to start us off?
Yeah, thank you. So I was born and raised in Kenya, and became a doctor because I wanted to make a difference. I had a chance to move to the US for college and did my medical training and my training in obstetrics gynecology, and now work in cervical cancer research. And I was attracted to this field because it is a disease of inequality where particularly women who are poor most suffer from this disease. And I think addressing cervical cancer is part of addressing, the issue of health equity and equity for women, and particularly poor women on the African continent.
Absolutely. And I think we lost Miriam. That's okay. So I think for me, one of the most important themes or undercurrent of themes that you shared was the importance of primary research in Africa. Just this idea that research in the Western context is not necessarily generalizable to the African setting. I'd just love to hear your thoughts more broadly on that and commenting on the importance of primary research on the continent.
Yeah, thank you, Christine. I think that's really critical, and it's something that's being appreciated more and more. The prior panel talked about NCI-led opportunities or supported opportunities for developing research talent. I think traditionally the field of global health has relied on a lot of data from the West, but we both need to, create and generate local data, but we also need to support young investigators or investigators in the continent because they're most likely to ask the questions, especially clinicians who are seeing patients in the day-to-day in sub-Saharan Africa. The right questions are often driven by the patients that you see. So, I think all of us, as we navigate guidelines, is always asking what is the primary data, and is the results generalizable? If the data, if the population that forms the results can't be generalized to your community, then it's hard to generalize it. I think that speaks to continuing to, if we are to achieve health equity and global health or reduce disparities, both address questions locally and also support local scientists who are most likely to address those questions or ask the right questions.
Thanks, Chamtai. And I think, Christine, you've both highlighted key issues around generating region-specific data. And I think even from your excellent talk, just the fact around how the risk of cervical cancer doesn't necessarily correlate with CD4 counts and things is an important observation, and certainly one that's pertinent in our region. I think what I wanted you to comment on is just the daily workings of these HIV clinics, because again, I'm maybe really reflecting on the role of the health worker. And I'll say that because we've had data presented at similar conferences where you find that we're getting our HIV patients getting diagnosed with stage 4 cancers, and they are, at least every month in interaction with the healthcare system. So what are the things that we could perhaps do or reflect on as a community to ensure that our patients get, the care that they require?
Yeah, that's an excellent point. And I think it's, really, a failure of vertical programming where the way HIV care has traditionally been funded was in separate clinics where, patients go and get their ART, they might have TB screening. But it wasn't until recently that, it's been acknowledged that they're failing women if they're coming every month to get their ART. But nobody has ever done a pelvic exam. And this is the only, unfortunately, because of the way, healthcare works, in many sub-Saharan African countries, a woman is not seeing another primary care physician who's doing her pap smears or who's offering her VIA screening. This is something that I think PEPFAR is now rectifying with the Go Further campaign, where they've chosen 12 of the PEPFAR countries that now will integrate cervical cancer screening as an integral part of HIV care. It's a start, but it's certainly not enough because it's 12 of maybe 40, 50 countries that now are having cervical cancer screening. But really, one of my mentors said, like, every cervical cancer diagnosis should be a reportable diagnosis and a reportable death, because it's very preventable and it's an indictment of the system. And I think as governments work with these programs that are funding individual diseases, like, first we need to perhaps move away from this vertical programming, but also think of the woman or the patient holistically. If she's HIV positive and starts coming to an ART clinic at 20, and she comes there for 20 years, you have to think about the other risk factors of diseases and either provide the services or very directly and very effectively link her to the services. And I hope that as we're thinking about the elimination agenda, we are thinking about doing those very good linkages between either provide the care at the HIV clinics or have very effective linking to other clinics that provide this care.
Wonderful. I do have a question actually about your actual study, and I think we also have one in the Q&A. Thank you for that. Please continue to post your questions. But before we change direction, I just wanted to probe you on the same line of thought as well, Dr. Mungo, which is, so what should we be asking more of our governments, governing bodies like WHO? What, in your mindset, where do you think the gap is to 2030? Like, what do you think we should be advocating for? Outside of doing good research, as you've so aptly shown, what should we really be advocating for? And I'm curious about, yes, you talked about co-affliction with HIV. What about, co-affliction with other NCDs? What should we really be advocating for?
Yeah, that's definitely, $1 million question that we can talk about for a long time. I think several issues. I like that there's a movement, in aortic, for example, towards implementation science. And there was excellent kind of sessions earlier in this Congress. And I see implementation science as like closing the know-do gap. Like, what do we know and what are we doing and how do we close that gap? I think a lot of, research or work is known, but we're not implementing it, we're not doing it. It calls for a lot of accountability. So, for example, in cervical cancer prevention, it's very common to have a lot of programs that report their screening data. This year we screened 3,000 women. Last year we screened 4,000 women. But, similarly to how when you go to an HIV clinic, they'll tell you, they talk about the cascade, number of people who are on ART, number of viral suppression, like you have to, so similarly for cervical cancer screening, you have to account, if you screen 10,000 women, approximately 10% had some abnormalities that should be treated. So you have to be very accountable that you should treat the ones you screened. It's not enough to screen at all. In fact, one can say it's immoral to screen and not adequately treat. And then following treatment, especially in the context of HIV infection, where we know there's very high rates of recurrence, it's particularly important that we are accountable for the women we treated, that they evaluated, a year later for recurrence and adequately managed, or those who had lesions that could not be treated and were referred. Did you help close that gap? Because we know that oftentimes just writing a referral form women don't make it. So accountability at all levels, including our governments, where we don't attend meetings and just present our kind of blueprints or white papers. We really talk about, are we accountable for the woman who was diagnosed with stage 1 disease? Did she access an oncologist to get the hysterectomy that would save her life? So I think accountability and really closing that gap of implementation and good data. It's like you can't do any of this with good data. Like every clinic that's offering screening and treatment should be able to say, this number of women were treated, this number was seen back, this number had persistent lesions, and were adequately referred. I think that especially is a gap that is often not closed.
Yeah, absolutely, Chamtai. And I think you've just really drilled down into the importance of things. I mean, and just ensuring that the entire pathway is covered, because, as you said, screening without, what next is actually criminal. And I think perhaps just maybe 2 questions, doing a little deeper dive into your study. And I think what was concerning was there's still pretty high persistent rates of the CIN after the initial therapies. Have there been any studies sort of going neck to neck with the thermal ablation, cryotherapy versus LEAP, and looking at what those look like, and maybe the subsequent follow-up for patients? I know your team was quite rigorous in doing the biopsies and probably maybe picking up a few more who may have fallen through the cracks. So maybe just your comments on that. And then as a follow-up to that, there's also been lots of new sort of toys and digital strategies, including, using cell phones and that kind of thing to sort of improve the screening abilities. Perhaps your brief comments on those 2 things and where you sort of see it heading. Is it, the silver bullet that's going to miraculously solve our health system problems? Just your comments on that.
Yeah. So I'll answer the first question first. So there's one randomized trial that's currently ongoing in Zambia that I think all of us are waiting for the results. That's randomizing women to thermal ablation, cryotherapy, and LEAP. And while they did not have biopsy at baseline for all women, it's going to be the best study in answering this question. And it's funded by the NCI, including other big funders. So, when I think those results will come out probably in about 2 years, and it's going to be really important to look at direct comparison, because we know that randomized trials are the gold standard. But in the meantime, I think the key thing is programs are doing ablation, especially in HIV positive women, need to be very keen on follow-up and being able to make sure that they can adequately evaluate a woman 12 months later per the guidelines. And if she has signs of persistent disease, she needs to be adequately referred to the next level, because that's how you literally save her life. There's
second question, there's some very exciting potential of using artificial intelligence in helping diagnosis, where you can take a picture with your phone and either connect a nurse in a rural clinic with the only oncologist who's far in the city, who can help guide treatment decisions, or even have artificial intelligence kind of read that picture and tell you whether or not this is a high-grade precancer that needs to be treated in a certain way. I believe there's a talk by Professor Grossbeck, who has done a lot of this work tomorrow at Aortic about this. It's very exciting, and there was a very good proof of concept study that was published recently that showed that you could train an AI algorithm to read a picture of the cervix and give you very accurate results. But that's still, I think, probably 3 to 5 years out, but definitely, keep an eye out. It might really, it might, bring very accurate diagnosis to rural clinics through a phone. where the alternative was to take a biopsy, send it to a pathologist who is far. So that the idea of the AI phone is that you could potentially get a pathology diagnosis, instantly. Very exciting, but still a few years out.
Really exciting. So thanks again, Dr. Mungo. And I really appreciate your comment on the question previously about importance of implementation science, in particular, because as you've aptly again noted, it's not so much just the tool or the intervention, but it's all the other actors, who's doing it, resources available to complement that tool, and so on. So one of my questions for your study was who was actually doing the thermal ablation in the study? It wasn't 100% clear, and I apologize if I missed it, but if you could speak to if it was the actual sort of on the ground folks, not study team members. I wondered if you could speak to the trainability, if there's any data on that for lay people to be able to acquire the skill set to be able to do that. And that was for the first question. The second question, just while you're thinking on that one, is about the use of your pain scale. I think the pain scale would be interesting to share for those that are particularly interested in maybe conducting a similar study. And the inherent question on that is your perception on the reporting of pain, right? So as we know, culturally, pain is sometimes undermined. And so I'm just curious about maybe if there's some comparable data that's looked at, pain reports associated with the procedure in other settings, or just if you could kind of give your reflections on that. So the first question is on the thermal ablation, who conducted it, trainability, and second on pain.
Yeah, thank you. Yeah, so in our study, thermal ablation was performed by a study clinical officer. So clinical officer is, like a physician assistant who provide a lot of care. Thermal ablation is actually very simple. It's very automated. The probe is heated to the appropriate temperature, and it's you kind of place it against the cervix. So it's a very teachable technique, and similar to cryotherapy, which has been done and is being done with nurses. It's something that is done by non-physician providers. So the fidelity in our study was really good because it was done by one person. I think anytime you roll out programs or you roll out treatments, if there's variability, then you might get differences in efficacy or outcome. But I think our study is a good comparison because it has pretty good fidelity. It was done by one person. So if a study clinician who's very well trained has this type of efficacy results, it might mean that the more people, if you roll it out to different settings and people of different training, the results might be the same, maybe even a little bit less. There might be less fidelity because of more variables. So that's, I think, something for our field to think about is, while the data that shows very good accuracy, who was doing it and how much differences was there in the technique that was being performed. So that's the first question. And then can you remind me of the second question?
The pain scale you used, and then if you could reflect
Yes.
on reporting of pain, of course, as it pertains to studies, and then of course, clinically.
This is a very good point. And I think it's, something that speaks to a lot of challenges of our health system, where oftentimes or patients underreport or suppress, or even we are unable in sub-Saharan Africa to adequately treat pain, or because of maybe supply chain, etc. For this study, we used a pain scale, and the reference is within the paper that I'm happy to share, and it's also open source, so it's you can find it at no cost. It's a standardized scale that has been used in HIV-based studies, and our data is very comparable to studies, data from Malawi on ablation that also showed very little or discomfort or pain. It's a very accepted, even in the US, when you do ablation, you don't use anesthesia. And our data is comparable to other studies, and we use a standardized scale that I'm happy to share. But I think it still behooves us to think a lot about, how we interpret pain data, because it's true that, for example, in obstetrics, sometimes there are certain procedures that when I trained in the US, you always use like an aspiration, you always use local anesthesia, but sometimes providers in sub-Saharan Africa have to do aspiration without local anesthesia because they don't have the lidocaine or don't have the spinal needle. I think it's a human rights issue that as we strengthen our health systems, we have to think about, pain is a vital sign. I think this was talked about in one of the palliative care sessions, especially in the context of cancer. Pain is a vital sign, and, it absolutely has to be addressed. And yes, so this is, I think, a question that all of us who practice have to really contend with.
Yeah. Thanks, Chamtai. And I think you have really touched on a couple of very key issues. Two questions. One really around more about the bits you'd raise around the potential sort of confounders if you were to sort of design a study to scale up your findings, what and how would that look like? And the second question is just circling back to, the core ethos of cervical cancer being a disease of disparity and inequities. What I would really like to know is, especially around your cohort and what's happening in the clinics, there's a very I think one of the key areas that we frequently sort of miss out on is patient empowerment and knowledge, because unless we're able to tell our ladies, hey, listen, you need to come in, maybe once a year, have a pap smear or whatever, or come for screening, whatever that form that takes, it would be just interested to know what are the processes around patient empowerment and really shared decision making, ensuring that they're central to that process. Thanks.
Yeah, thank you. Yes, I think the issue of scaling and how I would interrogate this question more. And there's, I think there might be a study that's looking at this in Zimbabwe is, for example, the length of treatment. The WHO guidelines say, each ablation treatment can last 20 to 40 seconds. So we don't have good data whether 20 seconds, 30 seconds, 40 seconds per treatment affects, the depth of destruction of the, precancerous cells and hence the efficacy. I think, it would be excellent to do even a pragmatic trial amongst different setups that are currently, doing ablation to look at, length of treatment, type of device. There's two different devices out there. Is there a difference? Perhaps the internal temperature of the probe is slightly different. There's definitely questions that are sort of low-hanging fruit that we can answer even within pragmatic trials. The question of empowerment is really critical, and kind of, this cervical cancer being a disease of poverty and, of kind of, the women who have kind of least agency. I think, particularly in the context of sub-Saharan Africa, I know when I was, growing up, you didn't ask the doctor a question, as when you were a patient, it was you heard, and you said, thank you, and you went. I think the culture is changing amongst younger physicians. And I think we both need the culture to change from medicine, but we also, continue to work with patient advocates for them to empower patients to be able to ask these questions and to normalize this. I think starting in medical schools, teaching future doctors that, it's imperative that a patient feels like they have a voice, that they understand, that at the end of each visit, have the patient, tell you what they heard and make sure that they heard it. So teaching young doctors that this should not be this top-down approach. Working with patient advocates. I think within cancer, for example, there's a lot of excellent patient advocates who are, supporting patients to know their rights. And so, we can work from both sides to make sure that, women and really we close that gap, the power differential between doctor and patient in the African context.
So great. Really enjoying this. I think we could go on for a couple hours. But with that said, we have a couple of questions from the audience that I wanted to pose to you, Dr. Mungo. So the first one, a really nice question. They're asking, did you look at HPV genotype concordance, at baseline versus 12-year follow-up? And I think they're really getting at the insight of whether there was a new incident cancer. So that's one question. I'll ask the second one. This is a bit more of a comment and something I think we've started to address. It's the idea of the need for strong follow-up mechanisms after treatment of a precancerous lesion. This person indicated, as you know, this is not the case in many LMICs. We give more focus on increasing uptake of screening, but not the same effort in strengthening the follow-up after treatment. So if you could just give your reflections on that, the need for follow-up after treatment as well, and strengthening our healthcare systems.
Yeah, so the question of the genotype is really critical. We know that not all genotypes are made the same, and 16, 18, 35 are more likely, harder to treat, more persistent. So we're actually having our biopsy samples being evaluated for HPV genotype testing. So we'll have that data in about 6 months, and then look forward to sharing it in the manuscript, hopefully in the next 6 to 8 months. So look out for it. It's really important because we know that HPV 16, for example, is very hard to clear. So perhaps, many of these women had HPV 16, and the question is not just ablation, but it's HPV 16 that, is difficult to clear. And the question about follow-up is critical. And I think that's something that we all really, really have to take from this, that, you cannot treat an HIV positive woman once and let her go or expect that it's done. I think it's very clear that the patient knows that this is a continual process, because we showed even with, the LEAP, which is a procedure where you take out the abnormal cells, recurrence is still high for various reasons. So, follow-up and accountability is really, really critical. And nobody should be presenting data only on screening. They really need to present that cascade where you treat it and then you follow it up. Because really that's where you prevent cancer, is the person who you treated and then has recurrent disease that needs adequate management. And so I hope that, we can continue these conversations, and each clinic, each setting can, always sit down at the end of the month and see who are our follow-ups and where are they, and are they adequately being addressed.
Fantastic. I think we just wanted to close Dr. Mutebi and I with this question, and then I'll turn over to her to summarize our session. For junior scientists and the young people, what can they do next as far as funding, getting into doing, again, this primary data, really excellent studies like you and some of your team? What are opportunities for funding? What can our audience take as next steps in terms of launching their own research on the continent?
Yeah, thank you. I think that, being hungry, all of us have, a contribution to make. I think that, we only have a minute, but I could talk about this forever, especially as African scientists. It's not common to see African scientists sitting at the podium talking about results of African patients. I think we need to change that. Be hungry, read a lot, apply for the grants. If you're not being rejected, you're not applying enough. apply, be hungry, be aggressive, and then just push through. Okay.
Dr. Mo, sorry, could you just comment on some funding opportunities, if you have any, especially those that are particular to the Africa context? Any suggestions for funding? Yeah.
Yeah. I think that there's several, so including the big cat. I'm happy to post some, in some of the blogs that are particularly for African investigators. I think AOTIC has some specific funding. Keep an eye on the National Cancer Institute. The NIH, often has funding. I think wherever you are on the continent, find institutions that are doing research and might have training grants that often have support for individuals within the country. I think just being very hungry. Follow people on Twitter and get on blogs. The American Society of Clinical Oncology has some funding for LMIC-based folks. I'm also on Twitter. I can be found and can help kind of guide people. But always ask if you know an institute within your country that does research. Talk to the principal investigator and just say, I'm interested. Can you potentially lead me or guide me? They might have no funding that's specifically for trainees in that country. So just, ask around and just keep trying.
Thanks, Dr. Mungu, for that excellent talk and discussion, and for my co-host, Dr. Ngaruya, for that excellent interaction, and to you, the audience. I think perhaps when we think of cancer epidemiology, we sort of have and Dr. Mungu sort of talked about these excellent opportunities, but sometimes I think the drive actually comes from within. As you said, as Dr. Chemtai is saying, be hungry. And sometimes you don't necessarily need complex funding to just answer. And this is a plug-in for health systems research. What are the pain points in your clinic? What are the pain points in your community? And how can you best address those? And some of these can actually just be simple audits, just looking at what's going on, what are patients doing, what is the experience, and all of these sort of comprise the bracket of pragmatic research that ultimately does have an impact on our communities. So I think we've had an excellent discussion around a pragmatic approach in Chemtai. Thank you for that wonderful presentation and relevance of the data that you're collecting to impact our population. So looking forward to more from you and from our audience. Keep, as Dr. Mungu says, be hungry, keep checking, and keep trying to solve the pain points for our populations. Thank you all once again. Back to you.
Thank you.
A great session indeed. But before we go, I just wanted to find out, Dr. Mungu, I really must commend you. I think the facilitators have given you a grilling in this session and tried to extract as much knowledge from you as possible. And I must commend you on your insights. And I could see from your presentation, the passion really came across with which you are doing your work in Kenya. So really, we need a lot more of women like yourselves that really take through the commitment, of research into gynecological cancers. And what I really wanted to ask you, and it's a burning issue. We keep talking of cancer control plans, and it keeps resonating all of the time across Africa. And all of us tend to move ahead and get these plans done. And 5 years later, 10 years later, we reflect, and the stats just keep going up. And we tend to wonder, well, what is it that we aren't doing right? So just a couple of things and maybe the facilitators as well. I mean, Dr. Mutebi, Dr. Ngaruya can also maybe comment on this for our delegates. I mean, firstly, in terms of Kenya, what can you say, firstly, with regards to cervical cancer screening, the uptake and the accessibility to screening and the linkage to the treatment? I mean, I know we had a brief question from one of the delegates, but I mean, are women responding to the screening program? And I mean, is there a linkage to treatment? So for example, if you were to send a mobile text message to them to come back for their treatment, are they responding, for example? Maybe a quick response to that in your experience.
In my experience, with good counseling, women are very responsive. There was a question in another session about acceptability of HPV screening. Self-sampling, very acceptable. I think, most women would prefer not to have a speculum exam, and they're very happy to do self-sampling. I think the key challenges are this health systems issues. For example, if you refer somebody who needs an excisional treatment, or for example, cancer be ablated, you refer them to a clinic at the referral hospital that's only open one day a week. They get there and it's full. And she, used her savings to travel for 2 hours to get there. That I think is where we're losing a lot of women. So really, improving our referral systems and, creating systems. It could be as simple as don't send a woman to a clinic where she'll have to wait and not be seen that day because it's full. Have a system where you call and book an appointment. So I know it's not very common to have appointment-based systems in, many public hospitals in Kenya, but maybe we need to move towards that so that a woman who, has to work for a living every day in the market, she doesn't collect all her savings, come and wait a whole day and is not seen. So let's, have an appointment system where she goes knowing that she'll be seen on that day. Let's have more of those clinics so that it's not just once a week. I think a lot of work needs to be done on that referral and closing that linkage system using mHealth, community health workers, patient navigators. That I think is where we're losing a lot of women.
Yeah, and I think I'll go next. And I know Dr. Mutebi is obviously on the ground, and I'm sure she has some rich comments on this as well. I'll speak to the mobile health technology comment, and then more generally on the SDGs and cancer control plans and so on. So first of all, mobile health technology, we actually did a study a couple of years ago with the African Population Health Research Center, Dr. Chibutumi and others, looking at acceptability of mobile health technology for non-communicable disease, linkage to care and referral to care from slums actually in Kenya, Viwandani and Korogosho, two of the largest slums there. And we actually found, and we published this paper, and I titled it Target Women, Equity and Access to Mobile Health Technology in an African Setting, because we actually found that women were actually twice as likely to access mobile health technology in that intervention. And it was actually very interesting because I think to the speaker's point, counter to our hypothesis, women's access and opportunities for mobile health technology, particularly in a home where there's usually one mobile phone. In spite of that, they were actually reporting increased likelihood of use even as compared to their male counterparts. So as Chemtai closed with, I think there's a lot of opportunities for mobile health. There's a lot of opportunity for technology, given the high mobile usage on the continent that continues to burgeon. The second point about just cancer control plans and sort of this defeatist stance that we continue to talk about at every single of these meetings every year is, I think, and the SDGs has reflected on this, is the lack of input from people living with disease. And I think Dr. Mungo also talked about that in her speech as well, which is that the SDGs, for example, were not reflective of incorporating the on-the-ground experience of those living with disease. And that's a big miss, because I think to the speaker's point, right, are they actually appreciating the treatment? If they have the treatment, why are they not getting from marketplace to clinic and back and so on and so forth? So hopefully, and I think there's some there was the last UN. The last WHA meeting, I think in May, they've made some recommendations to now incorporate some people living with disease to set some actionable points for Goal 2030. And so hopefully with that, we'll start to see better actual on-the-ground outcomes. But just to cite Dr. Mungo again, I think we all have to stay hungry. We all have to be advocates. We all have to be at the front lines, talking to our governing bodies, our academic bodies, and so on. So thanks for that, and turning over to Dr. Mutebi.
Thanks, Christine. And I think you and Chemtai have pretty much highlighted the issues on the ground in terms of basically ensuring, that these are getting the lived experience of patients. I think part of one of the key bits that is maybe missing is structured advocacy that kind of moves the needle in terms of improving care. Because if we look at it in terms of just health investment, the percentage of the GDP that's invested in health in sub-Saharan Africa, we find that most countries are hovering around, 4 to 5% or even less. If you compare that, say, for instance, to developed countries where we're starting off about from 11% and onwards, it just really, and framing the argument in such a way that we're not necessarily looking at it as health expenditure, more like health investment, and making the argument to policymakers. As clinicians, sometimes the weakness is that we're coming at it from a position of being really technical. Yes, we need the VIA. Yes, we need 1, 2, 3, but breaking it down into language that they understand to say, hey, listen, if you pick this up early and we say, N amount of years for this lady who, potentially is at the prime of her life and is, adding economic value to the community, then that's savings for the nation. And so if we're framing the argument in numbers and figures that they can understand, that also goes a long way towards that. I think also, just as you said, also looking more, especially for cervical cancer, I feel one of the bits, and reproductive cancers generally, I think one of the areas that we don't talk frequently enough about is, again, health equity, but also the social cultural barriers that exist. There's lots of myths around and stigmas around even HPV. The vaccinations. People think that you're giving a license to become promiscuous, and so there, we have all these programs rolled out, and we're wondering why aren't our communities engaging as much with them? So it comes down to sort of looking at what are the social cultural barriers, what are the constructs that exist, how do we begin to break those down to ensure that there's greater uptake of these services. And again, it still comes down to education and empowerment, because again, as Chimtai is saying, if somebody has to pay out of pocket for some of these services, then you're having to balance that between getting a meal, then you can pretty much guess which is going to be further down on the list. So I think raising an economic argument and addressing those social cultural barriers will definitely go a long way to actually ensuring that our NCPs, the control programs, don't just look pretty on the shelves, they actually percolate down to the populations that require them. Thank you.
Dr. Mutebi, very critical, which I was going to ask, in that when it comes to cervical cancer, including breast cancer, there's been a plethora of studies that have been done in Africa looking at barriers to screening uptake, whether it's lack of awareness of early detection, whether it's poor perception of breast cancer or cervix cancer, as you've mentioned, the socio-cultural factors and traditions and so forth. So having all of this information, my question was then, why haven't we acted on that? So we know all these barriers exist, right? And we know that is the key to the next step in terms of secondary prevention, right? We need to get these patients into the clinic. So why haven't we acted on that? Is it because it's too much of a social construct? Is it too complex? Because in Africa, we have too many traditions, too many cultural norms, too many barriers in terms of indigenous language. What is it? Because I think, the elephant in the room is, until we don't deal with this, we are going to have these barriers that exist. And no matter how good a cancer plan is going to be, until we get the patients through the door, we are going to have this battle. So my question is, why aren't we addressing these barriers? Then everything else secondary to that will flow.
I will. Should I? Oh, okay. Shamtai, go. You can go first, and I'll go next.
I think there's, like many things, there's not one answer. But, from where I sit, I don't think that so certainly vaccine hesitancy is one thing. But for example, secondary prevention, I think if we could provide services closer to where women are, some of these barriers are not, as like the social barriers. I I think, are not as big as we think if we can provide services where women are. And of course, as we talk about increasing, girl child education, and economic opportunity. But I see, while working in Western Kenya, the fact that women have to go so far to get services, many times with good counseling, they appreciate that, okay, this is something I need to do, but because of the barriers, the services are not where they are. So, the follow through is not as good. So, I think that yes, not everybody likes to do a speculum exam, but if services were more available, I think uptake would be much higher. I think that we really need to decentralize the services. From my experience, that would make a huge difference.
Yeah. And I think I agree with Dr. Mungo in the sense that if you look at the sort of three broad constructs as to why our patients are diagnosed late and why they frequently do not complete their care, we've kind of touched on, the three core pillars, which is one, the fact that patients are having to pay out of pocket for their care, frequently resulting in financial toxicity and, sometimes for catastrophic health expenditure. And then the second pillar, where we again talked about in our talk, where the health system itself is a barrier to care. If you're having to travel long distances, then you're not necessarily going to want to make that journey. And then again, even health workers, and this is where we hold ourselves responsible, where on average, patients in sub-Saharan Africa are seeing 3 to 4, even up to 6 healthcare providers before definitive diagnosis of their cancer or pre-cancers are made, just really shows the gaps that exist in the system. And so even in providing the services, but also providing the education and awareness for the health workers. And again, what Chamtai was saying about the integrated, and what Christine was referencing as well, just that integrated approach to care. You're not just here for your pressure. And this is an opportunity for mothers coming in for antenatal screening. That should be an opportunity to have a clinical breast exam, to talk about screening, or if she's coming in for, so just to look at her pressures and stuff. So it's the whole spectrum, looking at the patient, patient-centric approaches to care rather than sort of system-based approaches. And that's the second pillar. We've talked a little about the socio-cultural barriers, and that, I'd say, is just a third or even lower of some of the whatevers that exist. But as we say with any interventions, they do have to be culturally specific, resource appropriate, and having a nuanced appreciation of the community that you're in, and just understanding what's going on. And that's where we sort of circled back to the shared decision making, the empowerment, and really getting our patients to realize that we're only partners in their health, and they should be the primary drivers of their care. And I don't think that we're not, there's definitely much more that we could do, but much more needs to be done on all fronts. Yes, we can address the social cultural barriers, but if my barriers are broken and I have nowhere to do my screening, then it really doesn't help. Or if I do my screening and then I have nowhere, I will tell you, you have a cancer, but whatever you do next is up to you, then it's a problem. So it's definitely strengthening all these different pillars of the system, that with always having the patient at the center, I think is what needs to go a long way towards shifting the narrative in sub-Saharan Africa.
Awesome. And sorry.
I was going to add something, but
sure. No, just to go on the tailcoats of all those excellent comments. I think one of the issues continues to be this idea of a critical message. I love this quote from Richard Horton, who is the chief editor of The Lancet. He said that the NCD community needs an electric shock to its semi-comatose soul. And then he asks, who has the courage to deliver it? I think for many years, with the NCD advocacy and the NCD community in general, we were a bit placated. And I don't think we knew how much we're going to have to come up against this idea of HIV and target redirecting funders and attention for NCDs and cervical cancer and other cancers in particular. I think Dr. Mungo very nicely demonstrated the importance of aligning our messaging, including with that of HIV, and understanding that they are concomitant diseases, and making sure that funders and governing bodies are aware that, focusing on one without focusing on the other, meaning NCDs and cervical cancer in particular, that we lose the race big time. I think we're getting there, and I think we will start to see ourselves turning the corner. But I'm going to say the big D word, which is decolonization of global health, which is this idea that priorities need to come from the continent, right? From those on the ground, and not priorities of Western governments or certain foundations that think these are priorities. And so I will re-echo what Miriam said, structured advocacy. I think that's an excellent point. And then the second point I wanted to make was just about this idea of the conceptualization of a chronic disease on the ground for those in our communities in Africa, which is not something that's sort of, I think, well appreciated. We did a study of several years ago with Camry Wellcome Trust. Actually, this was hypertension screening study, in particular, putting blood pressure cuffs on patients to monitor for potential blood pressure. And we had this one patient's mother, I always remember this patient for many years, who was livid at us for putting this blood pressure cuff on this patient. What are you possibly diagnosing in my son that he doesn't have, and you're giving him a disease instead by putting this blood pressure cuff? If he doesn't have a symptom, hypertension is silent killer. As we know, a lot of the cancers also are silent killers until you have the symptom. So I think we need to reconceptualize this idea of chronic disease in the African context. And I think we'll be able to do that as well through personal stories, not just, sort of echo chambers like we sit here at Aortic. Of course, I think we're all very passionate advocates, but it's getting these ideas of the story of a chronic disease and the need for follow-up and the need for a continued care, not a one-off and done, or even similar to the HIV or malaria concept where it's a treatment that you're given and then you sort of go off for long periods of time without follow-up. So I think reconceptualizing it on the ground, and as I mentioned before, kind of this idea of us really continuing to remain fervent, and hopefully this decolonization of global health movement will help us with that.
Dr. Mutebi, final words from you. Dr. Mungo.
I just want to add that, in the fight against NCDs and cervical cancer, the oncologists will not lead the fight. Policymakers in Nairobi and Addis Ababa will not. It's the community health workers, the nurses who are seeing patients every day, and they need to really be empowered. We don't want to involve oncologists in cervical cancer prevention because by that time it's too late. And we need to really close that gap. When we say we have these meetings, we make these big policy documents in nice hotels, but really we need to be investing a lot of time in the nurses and the community health workers to understand the different, kind of risk factors to understand to help them offer that screening and help to navigate. I think that is where we can really get the biggest bang for our buck. And I think when we go back to physical conferences, we should have them in the community where, we can really understand what the challenges are and how we can help the real foot soldiers who are on the ground to do the work.
Dr. Mutebi, we certainly gave the session an electric shock before you had closed earlier on. So a final parting shot before we definitely close the session off from you. Dr. Mutebi.
Thanks so much. I think we've had an excellent discussion, and I think just to underscore Chemtai's need for having a multi-disciplinary, multi-sectoral approach to care, and really, as Christine is saying, reframing the understanding around chronic disease and basically even our health-seeking behavior, because people say, why do I want to go to the hospital and find something that wasn't there? We're saying, ironically, you do want to go and find something, because the earlier you pick it up, the better. But I think, as we said, just really, really making the push again for structured advocacy and advocacy from all key players, whether it's the clinicians, whether it's the nurses, whether it's the CHVs, there's definitely a need to collectively push for structured advocacy to actually have an impact on our patients. But again, always circling back to what is the lived experience and what are the pain points for our patients, and how can we start to break those down one by one. Thank you.
Well, there you have it. Some excellent points echoed by Dr. Mutebi, Dr. Ngaruya, as well as Dr. Mango, certainly my heroines for the day. So well done, ladies. You certainly carry the banner for Africa.